This is Shehzad Ahmed presenting the second video in the series of ECG lectures. In this video, we will discuss about heart rate calculation on ECG, the determination of axis, as well as the normal P wave and PR interval, and the abnormalities of P wave and PR interval, which will include left and right atrial hypertrophy or enlargement. Coming to the heart rate calculation, there are 4 different methods available by which we can calculate the heart rate on ECG. Of these 4, 3 methods are usually applied on a regular rhythm and 1 method is applied for heart rate calculation in patients where there is irregularity of rhythm. So for regular rhythm, a crude method is to count the number of large boxes between 2 R waves. If there is only one large box between 2 R waves, then the rate is 300. If there are 2 boxes, the rate decreases to 150. If there are 3 boxes, the rate is 100. If there are 4 boxes, the rate is 75. And if there is 5 boxes, then the rate is 60. This is a crude method, easily applicable, but less reliable and less precise. The other methods, we can count the number of small boxes between 2 R waves and we can divide 1500 by the number of small boxes to get the accurate heart rate calculation. On the other way, we can count the large boxes between 2 R waves and divide 300 by the number of large boxes between 2 R waves to get the precise number. And the last method for heart rate calculation is applied in patients with irregular rhythm, in which we take a 6 seconds rhythm strip and we count the number of R waves in 6 seconds and we multiply the number by 10, and in this way we get the heart rate in patients with irregular rhythm. Coming to the axis, there are a number of methods available for the determination of axis, but for the beginners and for the purpose of oversimplification, I have made this table. In this method, we only see lead 1 and lead 3 or lead AVF. Okay, we normally, in a normal ECG, both lead 1 and lead 3 or lead AVF have positive QRS complexes, predominantly positive QRS complexes in both the leads. This is a normal axis. And when lead 1 has positive QRS deflection but lead 3 or lead AVF has negative QRS deflection, then the axis is leftward. And when the lead 1 has negative QRS deflection and lead 3 or AVF has positive QRS deflection, the axis is rightward. And when the QRS complexes in both lead V1 and lead 3 or AVF are negative, this is called extreme axis deviation. This is an oversimplification. Other methods for accurate axis calculation are also available, but for the beginners, we will rely on this table. It's easy to remember. I always teach my students a trick that when the QRS complexes are facing opposite to each other, means when lead 1 is positive and lead 3 or AVF is negative, they are pointing opposite to each other. That means the axis is left, and when their beaks are coinciding, means that lead 1 is having negative QRS deflection and lead 3 or AVF has positive QRS deflection, then their beaks are coinciding and the axis is right. Before jumping on to the interpretation of P wave, at this point I want that the listeners and viewers must understand 5 basic concepts. The first is that limb leads record the electrical activity in frontal plane, that is, the electrical current moving upward or downward. And the chest leads record the electrical activity in horizontal plane, means that the current flowing towards the anterior chest wall or flowing away from the anterior chest wall. The second concept is that right-sided heart chambers are located somewhat anteriorly as compared to the left-sided heart chambers. The third important concept is that mean cardiac vector is normally directed downwards and leftwards. The fourth is that current flowing towards a unipolar limb lead or chest lead produces positive deflection in the tracing from that lead. And the last one is that if the direction of flow of current is parallel to the direction of a bipolar limb lead, it produces maximum positive deflection in that limb lead. So now we come to the discussion of P wave. P wave is best visualized in limb lead 2 and chest lead V1. Now we are going to apply the concepts we have already discussed, as the direction of limb lead 2 is from right arm to left foot, means it is directed downwards and leftwards, and we have already discussed that the mean cardiac vector is directed downwards and leftwards, and we have also discussed that when the current flow is parallel to the direction of a bipolar limb lead, then that bipolar lead records the maximum positive deflection. So as the direction of flow of current and the lead 2 are in the same direction or almost parallel, so lead 2 shows P waves the best. And as far as the lead V1 is concerned, we will apply the concept that the right-sided chambers are somewhat anterior to the left-sided chambers, and the second concept that the current flowing towards a unipolar limb lead produces a positive deflection, and the current flowing away from the unipolar lead or a chest lead produces negative deflection. So as the right atrium is the first one to depolarize and it is located somewhat anteriorly, that is close to the lead V1, so the direction of flow of current during right atrial depolarization is towards lead V1. So it produces a small positive deflection in lead V1 initially, and when the left atrium starts depolarizing, as it is located somewhat posteriorly, so the current starts flowing away from lead V1 and it produces a small negative deflection of P wave in the later portion in lead V1. So normally in lead V1, P wave is usually biphasic. And the upward component, as I have already described the mechanism of generation of P wave, it reflects the right atrium, and the downward component represents left atrium. The normal P wave is less than 2.5 small boxes in height and width in lead 2, and each component, the upward component as well as the downward component in lead V1, is within the constraints of one small box. When there is right atrial enlargement, the height of P wave in lead 2 is more than 2.5 small boxes, and it is usually peaked as is shown in the figure. And the upward component of P wave in lead V1 is more than one small box in height. When there is left atrial enlargement, the width of P wave is more than 2.5 small boxes with a central notch in lead 2, and the depth of downward component of P wave is more than one small box in depth or width in lead V1. All of these abnormalities are shown here in this figure. Before discussing the PR interval, I will discuss a concept about the ECG paper, that the smallest box on the ECG paper, when taken horizontally, it represents 0.04 seconds or 40 milliseconds. Normally, the PR interval spans between 3 to 5 small boxes, which means that it is 120 to 200 milliseconds in duration. PR interval is usually measured in the lead with the shortest PR interval to avoid missing of pre-excitation syndromes, which are important substrates for some arrhythmias. Short PR interval, when combined with the slurring of initial portion of QRS complex, which is termed as delta wave, it is called WPW or Wolff-Parkinson-White pattern, and when associated with symptoms as well as arrhythmias, it is called WPW syndrome. When the PR interval is short but is not associated with slurring of QRS complex, it is called Long-Genong-Levine syndrome or the LGL syndrome. And the prolonged PR interval represents a delay in conduction at the level of AV nodes, and it represents AV block. So here we conclude our discussion on heart rate determination, axis determination, P wave and PR interval. Thank you very much.